My name is Blessing Ugu. I'm a member of the Education and Training Committee of TORG, who are facilitating this webinar every 2 weeks. And I am thrilled to welcome you all to today's webinar. This is not just an ordinary webinar, it's a CPD accredited webinar with the topic, the management of central venous catheter. So you are all welcome. I would like you to sit comfortably, relax, sit tight, bring out your jotting material because you will have a lot of points to jot out in today's webinar. And if you have a question, please jot it out. When the times reach, you will be given opportunity to ask your question by raising your hand or using the chat box. Also, I also want to appreciate our speaker in the person of Dr. Jessie Mumba, who creates time out of no time to be here with us to teach us, this important topic. So when I'm done, a detailed introduction of the speaker will be done. I also want to appreciate our president in the person of Mrs. Adebusola Wokole, who always, give room to everyone, especially those healthcare professionals joining from developing countries who have access, who have, less access or even no access to such information. So we appreciate it, ma. Thank you, everyone, for trusting in us and joining us in today's webinar. You are all welcome. So the next thing is we'll be giving room to our proper introduction of our speaker. Thank you.
Good morning, good evening, good afternoon to everyone. My name is Alphonse K. Israel, and I'm speaking to you from a town in Namibia, Oshakati. So ladies and gentlemen, it's my honor to present today's speaker of our topic of discussion. So please join us in welcoming Dr. Jessie Musokota Mumba. Dr. Jessie is an anesthesiologist. He did an MMed of Anesthesia at University of Cape Town, a specialist anesthesiologist and director of Jesmuira Anaesthetic Practice CC in Namibia. Ladies and gentlemen, it is my distinct pleasure to introduce our esteemed speaker for today, for TORG's webinar on the management of central venous catheter, Dr. Jessie M. Mumba. Dr. Mumba is a consultant specialist anesthetist, bringing a wealth of expertise with a focus on cardiothoracic, neurosurgery, and geriatric anesthesia. His dedication to the field extends beyond clinical practice, and he serves as an honorary senior lecturer at the University of Namibia, focusing on the next generation of medical professionals through knowledge transfer and registrars and medical students alike. His journey in medicine has been marked by a global perspective, having undergone training in various jurisdictions from his undergraduate studies in Russia to internship at Zambia's University Teaching Hospital and postgraduate studies at University of Cape Town. Dr. Mumba embodies the richness of diverse education systems. Beyond his professional commitment, Dr. Mumba finds joy in company of his family and friends, drawn from diverse cultures and backgrounds. An artist at heart, he indulges in playing stringed musical instruments with a particular fondness in acoustic guitar. Please join me in extending a warm welcome to Dr. Jessie Mumba, whose expertise and passion promise to enrich today's discussion and central venous catheter management. I thank you.
Thank you very much, Israel, for that introduction, and welcome everyone from wherever you are listening and viewing this webinar. I will just go ahead and share the screen. I understand that we have limited time, so we will get straight into the topic of discussion for today. So can you all see my screen?
Yes.
All right, good. So today I'm going to particularly talk about the management of central lines. That's the topic that I've been given. And I just want to say that right from the start, it's a broad topic, and there are a lot of healthcare workers that are involved in the management, from the people who are inserting these lines and the people who are going to use them and look after them. So I understand that we have a broad perspective, and the audience is just as the same. So some of the things may be familiar to you, and if they are, let's take them as just revision and also emphasis on how we should look after the central lines. So to start with, these are the objectives of today. We're going to learn about the indications, the type of central lines, how we insert them, and then we're going to look more specifically at post-insertion care, which are famously referred to as bandos. And then we will look at some of the complications associated with the lines. I would ask that you mute your microphones so that we are all together. So I have a disclaimer. I've used a couple of pictures, and they are all from the internet, which are web access with no permission needed. And the other disclaimer is that I have no financial declarations that are related to this talk. So as we start, I would like to mention that with regard to central lines, it's how you start that determines how you're going to finish. So if you start adhering to all the things that need to be adhered to with regard to insertion, your finishing in terms of complications are also going to be favorable. So as we say, it is about how you start, and that's how you finish. So with regards to indication, we know that central lines are really not something that every patient gets, but those that need them are usually critically ill, or we have run out of venous access. And in most cases, we insert them for fluid resuscitation, and also for patients who are, as I've mentioned, critically ill and need medication that may sclerose the peripheral system, so vasopressors and other very well concentrated hypertonic solutions, such as parenteral nutrition, even administration of, say, 50% dextrose. They are also used for hemodynamic monitoring, and also when you have prolonged drug therapy, such as in the case of cancer patients who may need a couple of cycles. Also, like I mentioned, when it's not possible to obtain peripheral access, either due to the fact that this is a baby that is severely dehydrated, or a patient who's severely septic and they've gone into peripheral shutdown, central lines are usually the way to go. The other indication would be in very obese patients, and you can't just obtain a peripheral line, then you may need to use them. Last but not the least, these central lines are inserted for intervention purposes. So for people who are coming for hemodialysis, whether this is long-term or in the short term in the case of acute kidney injury, and also for those patients who end up with conditions of the heart that such that they have an AV node block, and they need either temporal pacing before you insert the permanent pacemakers. So when we start to look at central lines, we want to determine a couple of things. And one of the things we want to understand is how long are we going to need this line? So there are a number of lines on the market right now, and most of these lines will come with a duration of how long you can keep it. So it starts from 5 days and they go all the way to 6 months, depending on how you insert it, and we'll look at that. So in the interest of time, I know that people are going to listen to this talk. You'll be able to pause the talk and look at this nice flow chart in terms of how you're going to pick the central line of your choice. The common sites where we place these central lines, so we've got the internal jugular, which is up here, if you can see my cursor. Then you place them in the subclavian veins. We also place them in the femoral veins. And last but not the least, we do place them peripherally, which we call PICC lines, so peripherally inserted central catheters, where you can use a brachiocephalic and railroad the whole central line into the central compartment. The other one that we use the most in children are the intraosseous needles, which have a place for use, especially in the very dehydrated. So here are just a couple of examples. I know you're familiar with this type of central lines because these are the ones that we're mostly using. And then after that, we have the dialysis catheters. These are also inserted, like I've said, they can be permanent or temporal. And then we've got the sheaths. The interesting part with the sheath is that it's actually got a very large bore line where you can infuse even up a liter in under 2 minutes. So in places where you need rapid recess with fluids, this is probably your to-go place. And the sheaths can also be used for interventions. So when we're doing interventional cardiology, the cardiologist will place in sheaths, and through there they'll place in their interventional wires. And like I mentioned, when you're placing a temporal pacemaker, we normally insert the sheath, and then over the sheath, we insert that pacing wire. The one here in the bottom left corner is an intraosseous needle. So these ones are usually inserted in the bone, the tibia, the humerus, are some of the places of choice. The new ones come with the special guns. The ones that we used to use when we were interns, you would have sort of just screw them into the bone after a little nick on the skin. And then you can attach a port and a line to infuse. This is how the PICC line will look like. This peripherally inserted, so it's quite long and it's tunneled up, and these are chemo ports. So we put them into the central compartment and we bury this port under the skin. The method of choice of insertion is the Snellinger method. This is simply a catheter over a guide wire, and it's been proven to be the safest way to do central venous access. I've also included some videos here. So when the talk is shared, you can click on these links to see how insertion of central venous catheter is done. That said, this doesn't come without complications. So some of the complications are the fact that when we insert the guide wire, we may end up into the heart, and that causes arrhythmias. We can have injuries to vital systems, such as even the thoracic duct. And then sometimes you can lose that catheter if it nicks off, and then you're going to need further intervention from other subspecialties. Pneumo and hemothoraces are common, and also in where you by accident place it into an arterial or system or puncture. And these are some of the things that we're going to look at, the aids of how to avoid some of these complications. Venous embolism is also there. And I think the big one that we may look after we may specifically concentrate on is infection of the central lines. And we will talk about this a little bit further. So we've seen as to why we need the central line and when we need it, who should put it, and how it should be done. But I think from here, our next challenge is, or the next part of the talk will now just be to define one of the biggest complications, which is the central line associated bloodstream infection. And then we'll further look down into the talk as to how we are going to avoid this. So by definition, I've highlighted a couple of important points for you to make this diagnosis. This being the most serious complication of central line, because if it's not recognized, it may lead to sepsis, and sepsis unrecognized is almost a death sentence. So we need to be able to recognize this serious complication. And by definition, central line associated bloodstream infection is a laboratory confirmed bloodstream infection. That's important. You have to confirm it with lab tests. So you do infection markers, and they should be raised. But on top of that, you need to understand that this has to be in a patient who has a central line, and you have raised that suspicion. That central line must be in for at least 24 hours prior to these infective markers or the symptoms starting. And most importantly, when the culture comes back, it should not be related to an infection from another site. So the organism that you're going to culture when you take out the central line and you send the tip for MCNS should be the same as the organism that you found in the bloodstream. Otherwise, then that infection did not arise from the central line. So then how do we prevent this complication? It is simply by adhering to what we refer to as care bundles. And these are of utmost importance. It's quite disheartening when you go into an ICU or a patient come to theater and you find the central line that the dressing is soiled, the ports are not cleaned, sometimes even open, just clipped off. When I see such things, I actually want to find out who's looking after that patient, because then they need a bit more education on how serious central line infections can be. So we've talked about these central lines, and I just wanted to say that as far as infection is concerned, when you look at the frequency of where you find most infections, it starts in the femoral. And I think it goes by saying it's a bit difficult to clean the groin, and just nursing care may not be adequate. So the frequency of infection is usually the femoral site, followed by the subclavian site, and then the internal jugular has the least frequency in terms of infection. That said, we also have to look at patient comfort. So the subclavian line is quite comfortable for the patient because it's almost in an immobile area, whereas if it's in the neck or the femoral region, because of the movements, it's a little bit uncomfortable for the patient. But in the case of where we want to put them first, I think to avoid this serious complication, I would say that the internal jugular is much preferred so far as avoiding infection is concerned. So the first things first, and I think most of us work in the theater, as the name of the organization suggests. This is something that is familiar to us, but we need to re-emphasize that hand hygiene, not only when inserting the central line, but before and after use of the central line is very much important in terms of avoiding central line associated infection. This is just one of the ways that we get taught from the time we start our clinicals on how to scrub our hands. It's very much applicable in the setting of use and maintenance of central lines. Before insertion and before certain procedures that need to be done on a central line, we need to have the full barrier precaution. So this is where you get, you don on everything that gives that full barrier, from the cap and mask. You make sure that your hair is under the cap. You should wear that sterile gown appropriately with the gloves. And also you should have sterile drips that cover the patient after you have cleaned the area of the central line. When we talk of cleaning, how do we do the cleaning? This slide is almost the same as I've explained it. I think the most important part is to distinguish between medical asepsis and surgical asepsis. And if you look at surgical asepsis, because central lines are done under surgical asepsis, you can see that your PPE, your personal protective equipment, is all done under sterile. The field is sterile. And these are some of the examples of the things that you do with full sterile precautions done on. And central lines are just one of them. Okay. So how do we prep the skin? Quite a number of literature, and I think recently, or not so recent, there is evidence that chlorhexidine is more superior to iodine, but in a setting where you don't have the povidone iodine, you don't have the chlorhexidine, povidone iodine is a substitute. In the absence of chlorhexidine, which normally comes in about 70% alcohol, when you use the povidone, the recommendation is that you should also use alcohol afterwards. And you should scrub at least for 30 seconds. If you are dealing with the groin, you scrub for at least 2 minutes. All the tactics of scrubbing are needed. In this case, you start from the more clean area and you clean towards the non-clean area. And once you reach the non-clean area, you should discard that swab that you have used. Some of the central line packaging will come already with specialized scrubbing handles or swabs, and most of them will pack about 2 or 3. So you can probably start the old-fashioned way with a gauze on or a swab on a swab handle, and then you use the ones that are in the central line later. There is also a tendency to, because you want the drips to stick easily, immediately you finish cleaning, you want to wipe off the alcohol. The recommendations are that you should let that dry, or at least wait for a minute for the alcohol to evaporate. Especially in the case of chlorhexidine, the antibacterial effect goes beyond just when you clean it. So if you leave it on, it also gives you that layer of protection for when you put a dressing onto the central line. So I've talked about the infection part, but we also have to understand that there are other complications that can occur. And this is why we're saying that people who are going to be placing these lines need to have a certain level of knowledge in terms of site anatomy. And also, if they can be trained to use other aids such as ultrasound, this has reduced non-infective complications. So some of these complications can be injury to the nerve, like we talked about, puncturing the arteries, or nerve injury, and avoiding pneumo and hemothoraces. So we need to advocate for educating the people that are going to place central lines, both in anatomy of the regions they want to access, and also in the use of other visual aids such as ultrasound guidance. So I just wanted to mention that currently the recommendations are that use of ultrasound is actually compulsory. And this goes without saying. If we can look at the picture in the background, you can see the needle coming in, and you can identify the structures having linked the normal anatomy and then what we refer to as the sonar anatomy. So you can clearly see that this is the internal jugular. If you had an ultrasound probe, if you press on it, it will compress, whereas the carotid artery will not compress. And you can see clearly your needle coming in, and when you thread in your guide wire, you can also see it. The other thing that we normally do is after you place in your guide wire in this cross-section view, you want to look at the longitudinal view. So you're looking at the vessel in its longitudinal form. So you can see the whole guide wire running through and within the vessel, the lumen of the vessel. So this has improved and lessened the non-infective complications, but also its use can, if not properly used, you can actually introduce microbes. That's why there are also certain things that you need to do when you're going to use that ultrasound probe. So you make sure that it's also cleaned and draped. It's put in a sterile drape to improve ultrasound conductance. You need to add some gel within the sterile drape, and also the gel between the probe and the patient. And you always have to use sterile gels when you have done the draping and you are ready to use the ultrasound. Lastly, but not the least, it's always good to clean off your probe before you put it away, because the next person may need to use it, and in an emergency they may forget. But just be in the habit of cleaning all your instruments once you use them. So in the attempt to make sure that we are on top of our game as far as reducing back to the infective complication, you need to document what you have done, and everything else that you have used needs to be documented. So you need to document the site, the date, and the time, because remember at the start we mentioned that certain lines are meant to be used for certain days. So if it's a standard CVP, for example, most of them are 5 to 7 days. By the 7th day, if you're going to still need a central line, you need to remove that one and insert it in another place. If you have one that is long-term, we have the ones for 21 days and above, then you need to indicate the date when that line was put in, so that the person who's going to look after the ultrasound can quickly and easily see and be able to verify whether the line has overstayed or it's within the recommended time. And also the other thing that is a must that we do is upon insertion, we want to make sure that we have the catheters or the tip of the catheters in the central venous system where it's most effective without other complications. So we always order a chest X-ray. In an emergency, like in theater, we insert them and we use them, but even then, as the patient goes to the ward, the recommendation is that they should have a chest X-ray done and reported on, so that you can exclude things like pneumo and hemothoraces. Yeah, so now to the care bundles. What do we do now that the central line is in? We have to understand that immediately post-insertion, and we have to use them. The current recommendation is that we should put the needleless connectors. I'm sure you've seen these connectors where you can, if you have a lower lock, you can screw it onto the connector. If it's not lower lock, it's slip lock, you can still press down that blue line and be able to inject into the central line. So these are the recommended ones. we are no longer asking for you to put a cup that you open, inject, and then you remove again. We are saying, let's use the needleless connectors. But before use, the recommendation is to wipe them with 70% alcohol. And the way you do it is almost in a similar motion like when you're juicing an orange. So back and forth, at least 10 times, and then you can safely use it. There are other things that we need to do in the post-care. The question is, when do we change the lines that are connected? So we're saying that you change the giving set at least every 3 days. And in the case of where you have used a blood giving set, upon finishing administering the blood, we recommend that you clean the hub and you discard the blood giving set. In case you want to draw bloods from it, you still need to clean it with alcohol. And also, I must mention here that if you are going to use total parenteral nutrition, you need to have a dedicated lines. So if it's a 3 lumen CVP, one line is simply dedicated to TPN, and you never disconnect it unless you are changing the whole TPN bag. And when changing the TPN bag, the recommendation is that you should don on your full sterile equipment. Continuing on the post-incision care, so how do we make sure that this line is secured? We recommend that you always suture your central line and you apply a transparent dressing, and then this dressing should be changed every time it's damp or it's soiled. And for those that have access to this type of dressing with a nice jelly pad that's antimicrobial, you can change them every 7 days if it's not soiled or damped. But if you are using the gauze type of dressing, you should at least change every 48 hours. And then I've talked about this a bit in terms of when do we change the tubing. And I think we can, for this slide, the most important is that have a dedicated line for total parenteral nutrition. And when indicated, you use full sterile precautions when changing the line or the TPN bag. We're so serious about TPN because it's a very good culture for bacteria. So even when the patient is coming to theater from ICU, I normally tell the staff not to disconnect the TPN bag. They can disconnect all other lines that are not needed, but the TPN, we just leave it on and we move with the patient, because we don't want to introduce any bacteria in there which can easily grow, because TPN is a good culture media. So continuing on the bundles. Now, if you ever suspect that there is probably the infection, the patient starts to spike temperatures, or there's a change in the blood workup in terms of infective markers, how do you go about doing your blood test? So we're saying that the catheter tip, when you remove that central line, it should be sent out, cut out properly without it being in contact with other skin, with the skin. The moment you take it out, you cut the tip, you send it for MCNS. And we normally say that this should be routine, even in the case where you don't see infection. But if you ever have to do a blood culture from the central line, it should always be accompanied by one from a peripheral stub. This is just to make sure that if you culture something that's from the peripheral stub, then usually that indicates that that's not a bloodstream infection. You just didn't draw the blood well. And then as far as screening for infection, this should be done every day in a patient that has got a central line. We're not saying do the blood cultures every day, but things like monitoring septic markers, monitoring the patient for any spikes in temperatures, that should be done every day and recorded. Looking at the microorganisms that are normally cultured in the case of central line associated bloodstream infection, approximately 40 to 80% are caused by gram-positive organisms. And for the coagulase negative staphylococcus, these ones, you also find them, but they're not the most common. And in other cases, you may culture methicillin-resistant organisms. So what we're saying here is that if you suspect bloodstream infection, you remove the catheter, send the tip for culture, send the blood also for send another blood culture from another site, which is done appropriately as per recommendation. And then you compare what you get from the central line and from the peripheral stub. In the meantime, while you are waiting for results, you're going to start on antibiotics that are going to cover mostly the gram positives. But if you suspect for one reason or the other that it could be a methicillin resistant staphylococcus, then you also have to start the antibiotics immediately, broad spectrum, to cover these organisms while you wait for the culture. So everything else that we've talked about today, if we were to sum them up, we normally refer to them as care bundles, central line care bundles. And they boil down to very basic things that can save a life. And that is hand hygiene, needleless access. Make sure you clean that access before using the central line with at least 70% alcohol containing solutions for 10 to 15 seconds. You have to keep an eye on the dressing, and you should know the type of dressing that you have used. If it's a transparent, you can change it every 7 days if it's clean. And every time you want to change, you clean that central line area in a sterile manner, and you redress it. For gauze dressing, 2 days. And we are saying that for the administration sets or giving sets as they are known in other parts of the world, make sure that you change the ones that you are using at least every 3 days. And then depending on whether you are in a resource constraint, if you think that the lines are well kept, we can say we are allowed to keep them for 7 days. But if you are able, at least every 3 to 4 days, you should change the giving sets. Those that you've used for TPN, you should change every time you have a new bag. And every time you're going to change for TPN, I emphasize you need to don on your PPE in a sterile manner. And then for the access to chemo ports, you can, because these are lines that are also sort of long-term and under the skin, they still get line sepsis. And because it's almost a cut-down procedure, it's a little bit more of an expense on a patient that they have to come to theater for removal or insertion. So they still need, there's need to take care of these lines in an aseptic or even a sterile setting whenever we want to access them. Last but not the least, we need to make assessment of the central lines. The first question you need to ask is, does the patient still need the central line? If they've got a good peripheral line, there's nothing going through the central line anymore. For example, they were on adrenaline, which was stopped 2 days ago. Their condition that required them to be on an inotrope has resolved. You should ask yourself, does the patient need this central line? If you're not the one to make the decision, you should still ask those that need to make the decision, should we keep this central line? And once you say it's not needed on a daily assessment, it should be promptly removed. And also be on the lookout for change in infective markers and also the changes in signs and symptoms that the patient may have, pointing to the fact that they have developed a central line associated infection. With that, I'm going to end where we started. So if you start well, if you do all the things right, in terms of preparation, you've chosen the right line, you've chosen the right site, you've donned on the PPE in a sterile manner, you've cleaned the site properly, you have inserted it according to recommendation with all the aids that you need, like ultrasound. You dress it up, you use needleless access ports, and you do your everyday check. Do we need the central line? You are just going to finish as well as you started. And this is where I'll end my talk. These are my my references. I'm happy to share these slides with the organizers, and then they can distribute them through the networks. So, and I'm told this video is recorded, so you can also watch it at a later time. Thank you for your attention. I will take questions now, if there are any. I see Blessing has a hand raised. I'm not able to follow the chat, so could the moderator please check the chat and help us to see if there are any questions from there. Blessing, go ahead.
Okay, thank you, sir, for that wonderful presentation. Please, I have two questions. One of the question is, what if in a case that in a hospital you don't have this central line catheter, or a patient refuses it? Is there any alternative to it? Then the second question is, please, can you reemphasize the role of a nurse, in the care of this centralized catheter? Thank you so much.
All right. So alternatives to central line. So it like I said, it depends. If we go back to the slides, it just depends on what the indication is. So if your indication is such that you need to give, for example, vasopressors, you just have to explain to the patient that if they're given into the peripheral line, there'll be consequences, including phlebitis, and worse off, they could actually ulcerate that vein, and it would be a wound that would require a long-term management. And if the patient says they are uncomfortable, then you can ask them would they prefer a peripherally inserted line, this one. It's almost like a drip, but you feed it right into the central venous system. So that would be the alternative, the peripherally inserted lines. And as far as care is concerned and infection rate, they are the list, and they are quite long term. You can keep them from a month to even 3 months, these lines. So that would be the alternative. In terms of emphasizing the role of the nurse, I think the nurse will play the biggest role in terms of care of the CVP or the central line in general, because the nurse is the one that is going to follow the doctor's orders of what to give, what to do, how to connect, and everything. So I think they have the biggest role to play, apart from the fact that the doctor has inserted them. In terms of infection prevention, I think the biggest role will be with them. As far as at insertion, right at the start, all the other things were done right. then the ball really falls into the hands of the nurses to take care of these lines. So they are very important in prevention and even diagnosis or suspecting that there is line sepsis. And I always encourage in a working environment that my peers or even my juniors are very free to talk to me, because you never know what you miss. You know, sometimes the doctor comes there and prescribes things and walks away, and he may miss that the patient's temperatures are going up, or that white cell count is going up, and he may be thinking it's because of maybe there is some leak somewhere. But the nurse can then say, doc, the line has been in, this is the 5th day. Are we not dealing with central line sepsis here? And that can alert the doctor to further investigate whether it's central line sepsis. So the nurses are really at the center of prevention of central line infection, as it were. Any other questions? Israel, I see you've got your hand up.
Oh, thank you very much, Doc. Just to add a bit on what you just said there on the role of the nurses, in terms of record keeping as well, assessment and record keeping. Yes. So I've seen we have records that have been created as per institution on how to correctly monitor the CV central venous lines and everything. And I see there is also charts in the ICU department where most of the patients are being kept, whereby the nurse records from the date the line has been put up until the day it's removed, and the whole assessment of everything. So that's where the nurse come in. Record keeping, assessment, and communication through to the doctors and all.
Definitely.
And my question is, in terms of drawing blood from the central venous lines or central catheter, I wanted to know, is it safe? Does it have any disadvantages, or we can go for it? Does it play any major role in the results that are coming from the lab, in case you are drawing blood for certain tests from the lab or anything?
So it depends what the blood is for. If it's for a culture, obviously it will play a role. But if you are doing routine bloods, what I recommend is that the dead space in the dead space. Thank you, Lau. The dead space in the central line is usually about 2 to 3 mils. So you should get yourself at least a 20 mil syringe, 220 mil syringe, depending on the amount of blood you want. So the first you draw about 5 mils or 3 times the dead space. So if you draw blood and up to 3 mils, you've got clear fluid, and then the blood starts, then draw 3 times that. So that's going to be now about 9 mils. Once you get to 9 mils, then you are clear that all the blood that's in the tubing now is purely blood, not fluid. I say so in the case of when you are drawing for HB, for example. So you don't hemodilute that blood, and then the HB of a patient comes back as a 7 rather than a 9, which is above the transfusion trigger. So that's one. I think that's the only time these things play a role. If you're not drawing for screening of infection, you're just drawing routine bloods for U&E's full blood count. Once you have drawn at least 3 times the dead space, and then you connect the syringe that you want now to send to the lab, that should be okay.
All right, thank you very much.
Any other questions? And so,
okay.
Yeah, go ahead.
Hello.
Go ahead.
Please, there are some questions in the chat box, and I'd like to read it out.
Yes,
What about using heparin solution for clots prevention in central line?
yeah. So the recommendation, I'll talk specifically firstly for the dialysis catheters or the sheets. You should always, before you cap the line, you should always flush it with, again, at least 2 times the dead space. So if the dead space is 2 mils, you should inject at least 4 mils of heparinized saline, so that you avoid it being clogged or blocked. That's very important. For normal central lines, as long as there is going to be a maintenance fluid going through, I think it is fine. You can just flush with normal with saline. But if you have the heparinized solution and you know the concentration, say you've got heparinized solution that is 1,000 in 1,000, it may not change any clotting parameters for that patient. Then if you have that, it is recommended that you should flush always. So, but it's mandatory for the dialysis catheter, for the sheets, and also for the peripheral, for the peripherally inserted central lines, this one, and the ports. These ones, you always have to flush them with saline, because once it clots, it's useless. You need to remove it and then you put another one. And like I mentioned, especially for the ports and the dialysis ones, these things, you mostly have to insert them under some form of sedation or even anesthesia. So very important, flush with the heparinized solutions. Next question.
Next question in the chat. Is it advisable to ask patients with CVC to go home with it and possibly come back for change, especially with central line insertions?
So, especially in the private sector where cost is everything, sometimes you have patients who are with you simply in the hospital for TPN. So in that case, they can go home with the central line, and there are now these home-based care where some nurses have established home-based care units where they visit the patient in the comfort of their home and do this dressing. So that can be done. So it will not be done if you are now using that central line for something like, for example, inotrope. Obviously, that patient will be, you do not recommend for them to even leave the hospital. So for those who are on TPN for short bowel syndrome, or they have other complications that they need total parenteral nutrition to just boost their immunity and stuff, or people with cancer of the throat and they are not able to feed, those can go home. The other patients that can go home with the central line are the ones who have temporal pacemaker. So the sheath is left in, the pacing wire is left in, and they go home with the pacing box, waiting for the permanent pacemaker to be inserted. But all other central lines need to be removed. In the case of the intraosseous, it's mostly for resus, because when we are putting them in, it's either the patient has bled out or severely dehydrated that we can't find any lines. So we sort of put them up, resus the patient. Once we are able to insert any other lines, we remove them immediately. Other questions?
Okay, thank you. Yes, please. There's more in the chat box.
Yes.
There's another one. What's the longest time a patient can be on CV line?
So the longest time, like I said, the packaging dictates. So right now we've got the standard CV lines, which we say it's 5 to 7 days, but remove them at the earliest chance that the line is no longer needed. And then you've got the longer stay central line, which are up to like 21 days. Recently, they introduced the ones that have got silver chloride impregnated into the lumen. So that's more like an antibacterial. Those ones can go all the way to 60. We're talking about just the normal CVPs. Then if you are using the catheters for dialysis, you have permanent and non-permanent. The permanent ones, you can keep them as long as it's working, but in most cases, we try to use them as the interposition device. So you create an AV fistula for dialysis and you put in a permanent cath. While the fistula is maturing, the patient can use that. It normally takes about 90 days, which is 3 months for the fistula to mature for it to be used. In that case, they'll still be using this line. The ones with chemoports under the skin, these ones can go from 6 months to a year. So these will probably be the longest. I've seen a number of patients come to theater with chemoports, but they are not on necessarily chemotherapy. It's just that they are difficult IV access, and so they instead of using CVCs, the doctors opt to just put in a chemoport. And every time they come, these are patients who usually need some form of infusion every 2 to 3 months. So those ones you can keep it in for up to a year. Next one.
Okay, the next one is asking if we could get access to the slides.
Yes, I will PDF them and I will send them to the organizers, and then they can share the slides throughout the TORG network.
Okay, thank you very much. And the last in the chat says, tremendous lecture. Say thank you so much.
Thank you too, and
Thank
thanks
you
to
very much,
everyone
Dr. Mumba,
who attended.
for the insightful presentation.
You're welcome, and thanks for inviting me.
Thank you so much, Dr. J.C. Mumba. Thank you for the presentation. Thank you for sharing relevant knowledge. It's been so insightful. I've learned a lot. I know we use it in operating theater settings, and especially the setup, and it's very, very, sometimes you need to take precautions, especially in terms of infection prevention and control with the CVC line. So thank you so much for sharing that knowledge. I know the notice was even very short, but you still took the time out of no time to put up a very brilliant presentation. So we are really grateful for that. And thank you for honoring our invitation. We hope to see you more. So definitely we will have other topics in the nearest future. So I just want to use this medium to also say thank you to the TORG Education and Training Committee for organizing such a brilliant session, for facilitating the topics, and for moderating the sessions. I want to say thank you so much. And I want to say a million thanks to everyone that connected from all over the world. Good morning, good afternoon, good evening, depending on your time zones. There is another webinar in the next 2 weeks. Let me just share my screen so that everyone can see. So that's the next webinar that will be coming up, addressing burnout among staff and promoting well-being in the perioperative setting. So that our speaker is Dr. Gaston, is one of the TORG advisory board members, and is going to be presenting in 2 weeks. So thank you so much, everyone. More details will be shared as soon as we have them. As Dr. Jason mentioned, the slide would be shared when a link to the replay is posted across TORG platforms. So I want to say thank you to everyone for connecting, and have a lovely night or day ahead, depending on your time zones. Bye. Thank you, everyone.
Goodbye. Thank you.
Bye. Thank you so much.
Bye.